When it comes to transcranial Doppler, uh, if you are doing a stroke, you are called the vascular neurologist, and vascular neurologists are more interested in patency of the arteries. So if anything is to do with the patency of the artery, the blood flow in the brain, then transcranial Doppler is one very potential tool in your hand. You can do a vascular imaging using the conventional CT angiogram. You can do MR angiogram. You can do a DSA. And you can do a TCD. So I'm not saying that TCD is going to replace any one of them. What happens is all of them, they have their own beauties and all pitfalls. The information which is obtained from these investigations, they are often complementary. So if you combine the two, definitely your diagnostic accuracy will improve. The advantage of TCD are that if you know how to do a transcranial Doppler, it's a non-invasive, it's a bedside tool, it's relatively inexpensive. It has got a high sensitivity and specificity for diagnosing stenosis and other vascular abnormalities. This is the only modality to detect embolic signals. There is no other modality which can detect embolic signals. You can have indirect evidence that this was probably embolization, but if you really want to show that this was an embolus which came, you can detect this embolus with TCD. The only disadvantage which I feel during last 15, 16 years when I have been doing TCD is operator dependency. But I feel that every single skill is operator dependent. Good operators will do good TCD and bad operators will definitely do a bad TCD. Coming to diagnostic applications of TCD, the commonest which we use is intracerebral stenosis, especially for Asians where the stroke population may have up to 40 to 50% of patients may show one or the other artery inside the brain having a stenosis. The diagnostic accuracy, whatever criteria you use, it has got sufficient sensitivity and specific parameters to be used not only as a screening tool, but also as a diagnostic tool. You can use it against MRA time of flight. It holds true, especially if you're looking at the MCAs, which is the commonest artery involved, and even for the other arteries, including posterior circulation, good accuracy parameters are there for this to be used. You can compare it against a DSA or a CT angiogram. You can further classify your patients into moderate or moderate to severe stenosis using a criteria which we described as a stenosis to pre-stenosis ratio. That means if your flow velocity is at one point in the artery, they are jumping up by 3 times. This is equal to around 70% of stenosis. Instead of doubling means about 50% stenosis. There are many criteria. This is not the entire list. Probably I can fill up 3 or 4 slides only on the criteria which have been used in the world to diagnose a moderate MCA stenosis. You can pick up any of them and start using in your lab. The most important thing is that because all machines are different, operators are different, the techniques are different, you should use any one criteria, bring the patient into your lab and just do a validation. So validation is a very simple technique. Somebody on CT angio has diagnosed a moderate stenosis, bring to your lab and just see what kind of velocity parameters they fit into your lab. Do about 10 patients, 10 patients provide you about 150 samples, 15 arteries in each patient. And then you can definitely calculate what is the sensitivity of your TCD machine in your own lab. And then you can come out with your own criteria. So this is how either you diagnose and then send these patients for CT angiogram, or you do a CT angiogram or MR angiogram, bring it to your lab. It works good for both anterior as well as posterior circulation. TCD is all about pattern recognition. It's face recognition. You can see these are the various shapes of the Doppler spectra which we see, and every spectral shape, it determines that what kind of disease this person may be harboring. That's a normal shape, a sharp upstroke. There's a downstroke which is not very rapid. There's a substantial amount of diastolic flow. Brain gets perfused during diastole. So you should have at least 30 to 50% diastolic flow as compared to the systolic flow. On the other hand, you may have a person with AV malformation, which is a big malformation with big feeding artery. You can have a very low resistance waveform. You can have a very high resistance waveform in patients with diffuse atherosclerosis. You can have this kind of pulsus bisferiens in patients with aortic regurgitation. You can have this kind of delayed upstroke, which is seen in patients with severe aortic stenosis. So it depicts a lot of things, what is happening in your entire circulation, starting from the aortic valve all the way to the distal vessels in the circle of Willis. When it comes to stroke, we always teach that learn the stroke mechanism. what is the mechanism which is causing the stroke. And once you know the mechanism, you know how to treat this patient. Especially for Asian patients, atherosclerosis is so common that I told you nearly 50% of our patients, they harbor one or the other artery having a moderate or severe stenosis. So this is one example. This is a 69-year-old man who presented with recurrent TIAs. He had a CT scan which was normal, MRI was normal. It was labeled as TIA, which is the correct diagnosis. He was prescribed aspirin, but then he developed another TIA, despite being on aspirin and statins. So this is, I will just skip this one. This was not playing when I tried. Okay. So what you're hearing a sound like, ooh, ooh. There's a musical murmur. It's called a seagull sound. So this seagull sound says that you are dealing with not a moderate stenosis, you are dealing with a really severe stenosis. Something about 80-90% stenosis when you hear this harmonics in the sound. And once you add harmonics, tones and overtones, it becomes a musical character. So this is what is called as musical murmur. So this was the MR angiogram for this patient. You can see there's a severe stenosis on the left MCA. This was the velocity profile 257 over 148. This is accounting to nearly about 80% stenosis. Beyond it, the velocities will drop. So this is where we saw it. The question clinicians ask is, are we dealing with the TIAs because of embolization? Is it because of hypoperfusion in the brain? Or is it a combination of two? Most people believe it's a combination of two. When emboli go out in a slow flow state in distal circulation, they used to propagate. They may become bigger in size. Two emboli may coalesce together to form a bigger embolus. And there's a slow wash off of these emboli, which leads to symptoms. So it could be a combination of two as well. It's very easy. You just put the head frame, monitor for about 40 minutes. If you detect one embolus, this is enough to call that this is significant embolization, artery to artery embolization from this artery. Very easy to detect a sound like a bird chirping. It's a high intensity transient. They are called as hits, high intensity transient. They're microembolic, they're unidirectional, and the sound is like a bird chirp. That kind of sound will be coming. So you just wait for this sound to come in this video. That's the sound. That sound says, and you can hear this sound not only sitting in that room, you may be sitting in another room, because this is at least 3 decibels. That is 30 times louder than the background sound. You can hear in other room and you can go back. Yes, there was an embolus, and it needs to be treated with escalated antithrombotic therapy. You need to really give high intensity statins for these patients to coat the surface of the ulcer on the plaque, which was leading to embolization. And then you know what to do for these patients. On the other hand, this is another patient who is again having a severe stenosis and presenting with recurrent episodes, characteristic early morning headaches. So whole night she sleeps well, morning she has headache, and it's a daily feature. The headache remains for about 1 to 2 hours. She is doing all the daily activities, the headache disappears, and then the entire day she is well. So that's not the headache which we usually see. We see headaches usually towards the afternoon, towards the evenings, not early morning getting up. And she does not need any analgesics for it. Just doing the household work, the headaches will disappear. And again, the cause goes embolization, hypoperfusion, or again, a combination of two. We did repeated TCD monitoring for emboli, and we could not find. Perhaps we were very aggressive with the antithrombotic therapy and statins. Maybe that was the reason why we could not see it. But this is where we look for the autoregulation. We look for hypoperfusion. So brain maintains a constant blood flow despite having a stenosis, and we check it, is it able to maintain or not. Carbon dioxide is the agent which is the most potent stimulus to the brain for increasing the blood flow. And this is exactly what happens. If you increase the carbon dioxide by 1 millimeter mercury, the blood flow improves in the brain by nearly 6 to 10%. That's a minimum amount of blood flow which improves. So if you ask your patient to hold breath for 30 seconds, 25 to 30 seconds, your carbon dioxide increases by 3 to 5 millimeters mercury. So you see about 20 to 40% increase in blood flow. And it's very, very easy in the lab. You don't need any special machine. Ask the person to hold breath. And if the person is not able to hold breath, just put a paper bag on the nose and mouth and ask him to breathe in and out. You're just rebreathing carbon dioxide. Increase the same amount by 3 to 5 millimeters mercury over about 45 seconds. We use this formula, which was used actually for identifying high-risk patients with asymptomatic more than 80% carotid stenosis. So there are patients who are asymptomatic, having more than 80% carotid stenosis. There are some who are having a high risk of recurrent events. There are some who are having low risk. And that's a test. If the breath holding index calculated by this formula gives you a number of more than 0.69, these are low risk patients. The event rates are very, very low in these patients compared to those who are having an exhausted or diminished or impaired reserve. They are nearly 4 times higher risk as compared to the other group. So this is what we did for this patient. This is a condensed 40 seconds image. You can see the right MCA shows a correct response. As the person is holding breath, the blood flow velocities are increasing. They become nearly 1.5 to 2 times at the end of 30 seconds. But you look at the left MCA response. Instead of increasing, it is showing a paradoxical reduction. So this is an intracranial steal phenomena. And in 2007, we described it as a reverse Robin Hood syndrome. That Robin Hood used to steal from rich people, give it to poor. Here, the rich artery is stealing from the poor. So it follows, our brain follows the normal social norm. Rich continues to become richer, poor continues to become poor. So gap starts increasing. This is exactly what our brain follows. So this is how it was done. You can see it in this patient. The right side from 50 centimeters per second, it increased to 66 at the end of 30 seconds. The breath holding index was 0.89. On the other hand, the left side dropped from 22 to 19. So that's a drop. That's a reverse Robin Hood syndrome in this patient. You can use other modalities to prove it by parenchymal imaging. This is a SPECT imaging with Diamox challenge. You can see it at rest. The left hemisphere, little bit reduced metabolic perfusion is there. But when you give him Diamox, same, you are increasing carbon dioxide by giving acetazolamide injection. You can see there's a huge reduction in metabolic perfusion. You can calculate the steal magnitude. Once you know it, you know what to do. The antiplatelets, statins are not going to work for these patients. You need to improve the blood flow. You need to improve the perfusion. This artery was not considered amenable for stenting. Also, stenting has a controversial role at present. We did the STMT bypass surgery for this patient. And then when we repeated the same breath holding index, it became normal in 3 months' time. The patient is being followed up for 8 years only on aspirin, and nothing is happening to this patient. This patient is maintaining a very good life. This is the repeat SPECT which was done after 3 months of surgery. You can see it that most of the metabolic perfusion defect which was seen in the left MCA territory has disappeared. So this is how you can identify how to treat your patient. Now this was an interesting case, 22-year-old. This is a Vietnamese girl. She presented with recurrent episodes of jerking of the hand. And surprisingly, all jerkings happened in the examination hall. They never happened outside. They're all in the examination hall. She was a very bright student. She was not a weak student, and this is exactly what you can see. The hand just starts shaking like this. And once she comes out of the exam hall, everything disappears. Nothing was needed after that. So when I was doing the TCD, I said, let me just reproduce it, because I knew the pathology in her case, that she was having a very severe stenosis. So I said, let us see what happens to it. So you can see it, again, we are using carbon dioxide, but instead of increasing carbon dioxide, here we want to decrease carbon dioxide, because what was happening for this patient was, she was going in the exam, a difficult paper, she will start hyperventilating. And if you see children in exam hall, what do when they see the question paper? They do this sighing kind of thing. You do it 2 or 3 times, your blood flow drops in the brain. Whatever you remembered will also forget. Right? This is exactly what happens. Your performance goes down. So I asked her to hyperventilate. The entire video is just 5 hyperventilations, 5 deep breathing. You concentrate only on this number, 97.8. Our velocities are 97.8 centimeters per second, which is consistent with a moderately severe stenosis and MCA. You see what happens. Just keep looking at this number and keep looking what happens to shape. Keep looking at this number. This shows the resistance in the waveform, 0.63. Normal is up to 1.1 or 1.2 we take as normal. So just look at these 2 numbers with 5 hyperventilations. It goes to 63 with 1 hyperventilation. The PI has gone to 0.8. It goes down to 60, 57, 55, 50, 47. PI has already gone 1.21, 37, 35. See, with 5 hyperventilations, her blood flow in the brain in this artery had dropped from 96 to 35. It's a huge reduction, nearly 60% reduction of blood flow. And that reduction in blood flow was reflecting as a limb shaking TIA. You don't need to breathe really hyperventilation for a long period of time. You just need few. For young patients, especially females, they live on a higher sympathetic tone. You need just a little bit of trigger, and that was enough to stimulate this thing. And this was a SPECT for her, exactly same like the previous patient. There was no lesion on the brain. This was the stenosis in the MCA. She again went for the ST-MCA bypass surgery, and she has been doing very good after that. She has completed her studies. Young strokes are always a problem because we don't want young people to develop strokes and then get disabled. So this is a teacher, 46-year-old. He was writing on the blackboard. On one occasion, he could not use the hand. On another occasion, he just became mute. He could not talk. And these are very transient episodes. All investigations, CT, CTA were normal, ultrasound were normal, TCD normal. He had an MRI which was like this. By the time we saw, he was totally normal. This was the MRI. Multifocal infarcts all over the brain. Repeated monitoring for atrial fibrillation were negative. We know it that there is a right to left shunt, which is a potential mechanism in these patients. TCD performs this test in bedside. You can do in your office. You don't need anything. This is not the cigarette in the mouth of the patient. This is just a spirometer where he is going to blow air to create a valsalva. This is how this test is done. I will play the video. You just see these are the two middle cerebral arteries which we are going to monitor. This is the apical four-chamber view echo. This is the right atrium. This is the left atrium, and this is the left ventricle. This arm of the patient, he is having a cannula in the antecubital vein. There's a tri-way connected. There are two syringes with 9 ml saline and 1 ml air, and contains few drops of patient's own blood. We are shaking this solution about 16 times very vigorously to break this 1 ml air into micro bubbles. The blood of the patient contains lipids. These lipids will coat the surface of these bubbles so that they stay in longer time in the circulation. So what is going to happen is, you can see it that this person is, I need to play it again if it does not appear. Okay, this person is shaking the two syringes, then going to stop the tri-way, inject the solution, keep looking at the right atrium. See the right atrium become white in color. So air bubbles have reached the right atrium. So you know they have reached they take about 4 to 6 seconds, then do a valsalva. So this person is blowing air into this tube, seeing on the screen how much he is blowing air. And then you start monitoring. You can see that these signals, they are appearing on MCA. They are all microembolic signals. Air is going into the brain, these air micro bubbles. And you can see the air bubbles even on the left ventricle. So you know that there is a right to left shunt. You can do a TEE to diagnose where is the shunt, how big is the shunt, whether there's an atrial septal aneurysm associated with it or not. You know the characteristics. Once you know it, TCD helps you because TCD can be performed in different body positions. Our heart is full of blood. When you ask the patient to sit, the heart sets down. The same PFO, which was like a tunnel, it becomes like a gap. And more bubbles can cross. This is one person's, you can see the number of bubbles, each bright line is a 1 microembolic signal. You can see it once he's supine, the number of micro signals is not very big, but once you sit him up, you can see the entire screen is filled up with microembolic signals. You can do a quantitative scale grading of the shunt, how big is the shunt, small or big. And once the shunt is big, neurologists do a rope score to calculate what is the PFO attributable function for a stroke. And then you know what to do for the patient. Currently, recommendations are, yes, you can close. We came out with this recent publication showing what are the steps, what are the ways for Asia Pacific, that which patient should be closed, which patient should not be closed. This paper is written in a very simple style, like a road traffic signals. If it's a red color, you can go ahead, close it. If it's a red signal, then probably don't do anything. If it's an orange signal, then you have to think again and again whether you really want to close this or you want to leave it alone. It's quite a safe procedure. We have been closing a lot of patients. We closed this patient, and this patient never had any problem. Has been only on aspirin, which was given for 6 months, and after 6 months, we even stopped aspirin. So he's not on any medicine since then. So you can avoid even giving unnecessarily antiplatelets or antithrombotic therapies long-term or lifelong for these patients. In acute stroke, I'll just go like this, that an acute stroke, when you see the patient, your aim of treatment is doing recanalization. You want the artery opens up, the clot disappears. When we do endovascular treatment, we see in real life how the artery recanalizes. But if you want to see how artery recanalizes in front of you, if you are not doing an endovascular therapy, you can put a TCD probe and you may be the only person witnessing how the artery opens up. You can see in this patient, there is no blood flow in the MCA. And as you are giving TPA, you can see the blood flow starts improving. There's a minimal blood flow which starts appearing. And the blood flow starts becoming better, and at the end, it's going to become a totally normal flow with substantial diastolic flow in the brain. So you can see in front of you how the artery opens. So you feel very satisfied that what you wanted to do, you have achieved it. You don't want to do any further thing for this patient. You see in real time, how the patient's power is improving in the hands. For prognostic uses, it's a monitoring tool. It's a wonderful monitoring tool. This is one patient who had subarachnoid hemorrhage. You can see how the things progress from day 3. The flow was like this, having a vasospasm. The vasospasm continued to progress, became a higher resistance waveform, and became this is called as a reverberating blood flow. What you're seeing here is in systole, the blood goes into the brain. In diastole, brain is pumping the blood out. So blood is going into the brain, same amount of blood is coming out in the same artery. So nothing is moving. Net flow is 0. The flow towards and flow backwards is equal. So net flow is 0. This is called a cerebral circulatory arrest. We never diagnose with TCD brain death. Brain death remains a clinical diagnosis. You need to satisfy all other criteria, but TCD helps you to prepare the patient early, which direction patient is going, and you can see that this is what's happening. And once you know the ICP, yes, you are having a wonderful tool in your hands that something is changing in a drastic manner. Subarachnoid hemorrhage, TCD has a huge role, especially for monitoring, diagnosing vasospasm. I'll rush through this one. This is a young lady who has an aneurysmal rupture. That was the aneurysm on the left MCA. You can see the aneurysm is there. We coiled the aneurysm, so it was very nicely coiled. On day 2, this was the TCD, which was looking like a normal. So this is a normal looking waveform, but on day 4, she becomes lethargic. We do a daily TCD for these patients, and you see what happens. She has developed a severe vasospasm in both middle cerebral arteries. And to compensate for is the basilar arteries trying to increase the blood flow through the PCOMs. So this is trying to compensate. We escalated double H therapy. Day 5, she became aphasic and she developed a right-sided weakness. And if you remember, I showed you the initial TCD. You see what happens to her TCD now. This is no longer systole. It's a flat flow like a river is flowing. So this is a heavily vasodilated blood flow. We call it, this is the last set of collaterals which have been recruited called transcortical collaterals. So this is not the normal flow. And you can see, compare, this was on day 3, the waveform. This is the waveform on day 6, totally different in the same patient. We took this patient for CT perfusion. You can see there is a prolonged MTT. There's a reduced cerebral perfusion. This is the time to take this patient for angio. You can see how severe is the vasospasm in both MCAs. It's just like a small thread which is visible. We injected nimodipine. We aggravated our triple H therapy. Just 1 day later, the vasospasm improves. It resolves completely. Patient improves. CT perfusion improves, and patient achieved modified Rankin scale of 1 at 3 months. That's the best outcome which you expect in a young patient. Some interesting uses which you can use if you know TCD. It can be a tool to monitor vasculitis, especially like TB meningitis, where the vasculitis is indwelling, it's for a long period of time. You want to monitor, you want to see whether your steroids which you are giving are enough, or you want to escalate your steroids because the vasculitis is progressing. On one single test, it does not tell you anything. But once you monitor, you know there's no reason why the thing should change so fast. Sickle cell anemia, luckily we don't have sickle cell anemia here. Otherwise, this has got a recommendation level 1A, where you give blood transfusions depending on your TCD findings. Don't give blood transfusions based on hemoglobin levels. Just give it as soon as the TCD MCA velocities, they go more than 200, give blood transfusion. No other criteria is used. You can prevent 92% strokes. The relative risk reduction in that trial was 92%. There is no treatment in stroke world which is having so much of efficacy like 92% relative risk reduction like in sickle cell anemia. It's not a tool for measuring ICP monitoring, ICP in a particular patient. But if you have a patient where there is a fluctuations in ICP because of a disease, you can do serial TCDs and you can say ICP is stable, ICP increasing, ICP dropping. You can do these things. Just some special things, just last couple of slides. So, you know, when COVID came, all of us, we started wearing N95 masks. And what we realized in the hospital, most of us, we started getting headaches towards the afternoon. And we said, why are we getting headaches? We thought maybe the straps, they are pressing on some of the subcutaneous nerves. Maybe something else is happening. We knew it, that there's something which is happening to us, that we wear the mask and we get headaches. This is what we did. We found that your carbon dioxide increases nearly from this level to this level if you are wearing an N95 mask or the KN94. This was being done with the American group. We were measuring their end-tidal CO2s, and we were looking at it, how to overcome this thing. And what we found was the moment you use a PAPR, the carbon dioxide goes back, the headaches disappear. We did a small study here, and you can see it exactly what happens to us. This is your blood flow at rest. In room air, the moment you wear N95 mask, within 5 minutes, your blood flow starts becoming like this. It's vasodilated blood flow. And once you live on a vasodilated blood flow for more than 10, 15, 20, 30 minutes, you start getting headaches. So we found that up to 4 hours, people are okay. It's 4 hours limit. So probably if you have to wear the N95 mask, you need to take a rest, a gap of few minutes after 4 hours, and then you can continue using it. This is exactly what happens. When you wear the N95 mask, your flow velocities jump. Your resistance in the artery drops as your carbon dioxide is increasing. You use PAPR, which is just pumping air, which is outside the mask, the air is being circulated, everything returns back to normal, and you can continue to do it for hours and hours and hours together without having headaches. So one of the components which causes headache wearing N95 masks is the carbon dioxide accumulation. I'll stop here saying that this is a wonderful tool. This is a very reliable tool in good hands to see what are the blood flow changes happening in the brain. And once you know they are changing, then you can just analyze what is the factor which is causing these changes, and you can treat it accordingly. Thank you very much.